Hello, welcome friends. Today, this is a very special episode of Put People First series in the lead up to the 25th International AIDS Conference, which is the largest AIDS conference in the world for this year, also referred to as AIDS 2024. So let us talk to someone who has been a big inspiration for me personally. And especially I'm saying this because if Doctor, please correct me if I'm wrong. I think it is at least 20 plus years ago when we were moderating Asia Pacific e-forum, electronic discussion forum on HIV/AIDS, and the Global Stop TB Forum, which was founded for a lead up to Stop TB partnership. Dr. RK Sood was a name familiar to all of us. Dr. RK Sood from Kangra, Himachal Pradesh. He has been one of the most vocal persons for people's rights, people's health, and especially connecting the dots between not only tuberculosis and HIV, but also a lot of other issues like NCDs, nutrition, water. When I went to, I was very lucky to meet him in person a few times. And it's a great coincidence, sir, to happen to meet you in Kangra. And I remember you were mobilizing local support so that when patients and people come to access TB services, they have clean, potable drinking water, for example, with support from local communities, and so many other little things. He has played a very key role in shaping Kangra's health responses. Right now, he's working as District Program Officer of National Health Mission in Kangra, Himachal Pradesh, India. My personal conviction is that probably Himachal Pradesh, Kangra will be among the very first few who will be, touching the NTB goalpost. And we really pray that his efforts bear fruits. Welcome, Dr. Saab.
Thank you, Bobby Ramakant, for having me on the show. And it's a real pleasure to be in touch with the global community through your esteemed platform. And I think CNS News is doing a wonderful job of taking these issues forward and the debate for having a better accountable services. So I think it's a really nice to be here in your show.
Thank you so much, Dr. Sood. We are very small team, but in my heart, I really feel that we are part of your team too. So, Dr. Sood, you have really played on the front lines. You have played a very important role. I think everyone who is working in health will probably be familiar with your name, and they will probably associate you with TB. But I know that you have played a role in HIV and other spheres as well. So, a person who has seen TB, people with HIV responses, NCD responses, other issues which are connected to health like water and others. So your opening remarks, sir, like how, in terms of TB, HIV co-infection, in terms of ending TB and ending AIDS, your opening remarks, sir.
One of the good things that's been happening since 2018 is we are offering TB preventive treatment to all the people living with HIV, screening all of them. Initially, the coverage was low, but with time and efforts, we have been able to scale it up to nearly 100%. And it's a very good team effort from our ART center, our ground staff who are understanding this. Initially, we used to have coordination meetings between the ICTC and the TB staff at a district level. But when we found that the district level is too big for exchanging line lists, so we decentralized it to the ICTC and the TU level. So they used to meet there, exchange line lists, have their minutes of meeting, and individual patients could be tracked in those meetings. So what I understand is that we need to decentralize further and further. Like in the National Health Mission, now we have the health wellness centers, which are now called Ayushman Arogya Mandir in India. So the community health officer is the lowest, doorstep facility. So they are giving the TB services, though HIV services are not yet decentralized to this level. But uh, the further we build the capacity, the greater the stigma reduction will be there. So stigma reduction is the thing which I understand as put people first. Like for TB, we did a this thing engagement with the community health officers, and the community health officers are now very comfortable on providing the TB services. So I think one of the good things could be to train the community health officers on HIV also. Like one initiative we took last year was capacity building of the community health officers on the HIV/AIDS Act of India. So this HIV/AIDS Act protects the rights of the communities, and the CHOs initially, and even our health professionals initially took it as like this a very anti-health professional act, lot of penalties, lot of things against us. So then we again explained it to them that why protection of rights is very important in the HIV response. So this approach, changing mindsets of our healthcare teams is, I think, one of the first things we need to take forward to improve the services, make them client friendly, and make them more accessible. And recently, we are having a very good campaign in India, which is an integrated campaign for HIV, STI, hepatitis, blood pressure, diabetes, and anemia. So, having such integrated campaigns will remove the stigma from the testing, because otherwise, if a camp is labeled as a HIV testing camp, there is a stigma attributed to that. And when we have it as a comprehensive health checkup camp, I think more people can access those services without any fear or being labeled as immoral or having any shame associated with that. So this is one of the good things that's going forward. And one of the good news from India that I'm sharing is that the 1 HP regimen, which is a shorter regimen for TB preventive treatment, is about to be rolled out. I just confirmed with our national team, and they told me yes, it's on. So we have the supplies in place, the guidelines are there, and I think shortly, instead of a 6 months TB preventive treatment for PLHIV, we'll be having a 1 month TB preventive treatment. So that is going to be a very, very big game changer. So the very big step from the Indian government in putting people first. So lot of good things going on, though everything is not so rosy. We have had medicine stockouts in India, NAT cartridges stock out in India, but now those things are beyond the shelf. Now we are over it, and now like supply chains have restored. So we are like on the fast track towards ending TB, HIV, and achieving the SDG goals in the UNLHM. So very, very optimistic, and lot of things have been done, but many more are yet to be done, I think, and it's a continued learning, which I would say that we are always learning day by day with our experiences, with the experiences of our team. So that's the way like we move forward, we work, we learn from our mistakes, then we improve it further. So I think that's the way we are trying to accelerate our efforts towards ending TB, HIV, and NCDs. So one of the very optimistic news that I would like to share through you with everybody.
Yeah, so, oh, sorry, I was on mute. So, yeah, first of all, sir, congratulations. Again, you are leading from the front. 1 HP is such an important regimen, especially because it's shorter. I think, sir, it is rifampicin and isoniazid for a
Yes,
month, right?
yes,
Yes,
yes.
yes. Imagine of the difference it will make. We'll come back to that. But this is really game changing, and especially path setting, because you will be now. I hope that other districts and cities and states follow this, and this really becomes a reality for everyone. 1 month regimen for preventing tuberculosis transmission, latent TB to active disease. So thank you so much. Dr. Sood, to help us understand, can you please let us know how do we find TB among people living with HIV? How do we screen them? Are we screening them with X-rays and testing them on molecular tests? Or are we screening them just verbally asking for symptoms? Because, sir, as you know, the India TB prevalence survey report of the government in, I think it is 2019 to 2021, it probably showed that how over half of the patients were asymptomatic. So if we need to catch them early, if we need to find them early, I should not use the word catch, but we need to find them early.
Yeah.
If we can find them early, probably we need to really use tools like X-rays. So can you just give us a sense how how do we look for TB in people living with HIV in program setting? Yes.
Well, TB is the one biggest comorbidity in the PLHIV, and you're totally right that the 4S verbal symptom screening is not sufficient. But right now, I rechecked with our team. They are doing only the 4S verbal symptom screening, and anybody who has any symptom, we do upfront NAT testing, nucleic acid testing. So anybody having any symptoms, we do nucleic acid testing, but we are still not transitioned into that doing point of care handheld X-rays, and that's a big gap which we are trying to like address. Even for TB, we are looking for CSR support to get those machines point of care handheld X-rays because they are not yet provided by the program. So that is definitely the next frontier because the National TB Prevalence Survey of India shows that having a chest X-ray picks up a lot of early people, and we have our experience in a jail setting where people did not have any symptoms, and in collaboration with the Tibetan government, they have a handheld portable X-ray. So they and the Rotary people and we jointly did a screening camp in the jail, the district prison, and we got a yield of 88 out of 400 prisoners. So such a high yield of presumptives. So definitely this is the new frontier, like having point of care this molecular test as well as point of care handheld ultra portable X-rays, and I think we need to scale up into this.
Yes, yes, you're so right. Let us hope that this becomes a reality soon, sir. We really need to scale up the deployment of point of care tools. As Dr. Luchika Dityu of Stop TB Partnership, she said some months back, I think, in one of the sessions, that by taking services to the people, closer to the people, we remove many barriers which people may be facing in accessing those services. So it could
Right.
be difficult to reach areas, it could be socio-economic, it could be a range of other barriers. So now science has gifted us tools which are battery operated, lab independent. They can be really be deployed at the closer to the communities, literally at their doorstep. Even artificial intelligence and made in India, even, which is so better. So really hope that what you just said really translates into action on the ground. Dr. Sood, can you please help us all understand what about extrapulmonary TB among people living with HIV? Is it more common? Is it less? And how do we look for extrapulmonary TB? Because that probably will not be caught with four classic TB symptoms. Over to you, sir. Yeah.
Well, extrapulmonary TB has always remained a challenge, and uh, we need better tools to diagnose them, evaluate them, and often people will need to go to medical colleges for the diagnosis. So, what happens in our setting is that ART center is in the medical college. So, if somebody has a lymph node, then the surgery department will take the FNAC and then will subject the FNAC sample to this CBNAT. But it's not so simple. Lymph nodes is the easiest to access, but abdominal TB and other TB, extrapulmonary TB, is quite difficult to diagnose, and often there is a delay in diagnosis. So constitutional symptoms, other supportive tests, help us suspect that there's something wrong, and maybe the condition of the patient deteriorates, and then we try to suspect. So still, like, extrapulmonary TB is a challenge. Recently, the Indian government, the AIMS and a very big committee updated the guidelines for extrapulmonary TB diagnosis. So extrapulmonary TB has always been a bone of contention, and like, no consensus was there earlier on how long to treat, how to diagnose. So the new guidelines, we did a series of CME on extrapulmonary TB with all the nodal officers in all the health institutions. So we expect that there will be some improvement in the early detection of extrapulmonary TB. And one of the good things that I can tell you from here, um, the most expensive tests which lead to the out-of-pocket expenditure is the CT scan and the MRI scan. So the government of Himachal Pradesh has made both these tests free. These tests are not covered under the free diagnostic scheme of Government of India. So these tests are free under the state government scheme, which is called the Mukhyamantri Yojana for TB. And in case somebody's already spent the money, we'll reimburse the money to the patient. So that's how it operates. So we are trying to decrease the out-of-pocket expenditure, because extrapulmonary TB leads to a lot of out-of-pocket expenditure. The person has to travel a lot far away from his home, and though we are not able to reimburse the travel expenses, but or at least the diagnostic expenses we are able to reimburse.
Yes, thank you so much. This is very important that you mentioned about the, the coverage of CT scan and MRI, one of the two big out-of-pocket expenses otherwise for people. And it is so great that the Himachal Pradesh government, covers for these two services for those in need. Very, very important. As Dr. Sood, as you, I remember you emphasized last year also when we spoke that diagnostic delays are, we really need to reduce diagnostic delays, because diagnostic delays not only lead to unnecessary human suffering, but it also spread, the infection keeps spreading. And I remember your powerful words, Dr. Sood. So please allow me to try to quote you, but I could be a word here or there. You said that every TB death is a grim reminder that we could have done better in terms of preventing the disease, in terms of early diagnosis, in terms of taking care better. It was such a humbling moment to read and to listen to those words, sir. And I really hope that TB responses are able to eliminate diagnostic delays. A recent study found that over half of the people who face diagnostic delays in India, they face it before getting diagnosed.
Yeah.
So, which is really, this kind of catastrophe, because diagnostic delay is not only diagnostic delay, it comes with catastrophic cost. And it's good that the government of Himachal Pradesh is covering for some important tests, which are very, very expensive, like MRI and CT scan. But we really need to eliminate diagnostic delays. So, Dr. Sood, let us come to the prevention. As you have already probably said, highlighted few things we can do to prevent TB. You spoke about the shortest and the best possible TB preventive therapy regimen, 1 HP, rifapentine and isoniazid. Just 1 month therapy, and people with latent TB will have probably very no risk to convert into active disease. TB treatment is prevention, sir. Sir, please correct me if I am wrong. If a person with TB is treated with effective medicines, the infection stops spreading from that person. Is it true?
Definitely, sir. Infectious diseases, early detection and prompt treatment, and further, the early detection and treatment of latent TB is life-saving. It's a very, very good thing. And beyond the PLHIV, we are also implementing the TB preventive treatment for the general adult population also, and we are getting very, very good results. And the tolerance is very good. The adverse drug reactions are less than 1%, and it's very acceptable. Like earlier, people used to come to us and ask that, and the family members of the patient would ask that if this person has TB, now what do we do? So earlier we could just tell cross ventilation, good nutrition, take care of this man, and if he takes proper diet and proper medicine, then it will be good. So now we have next thing to offer that, okay, you all may be having latent TB, so get yourself tested, and if you this thing. And the next thing that's coming up in India is Sci-TB. Sci-TB is a very revolutionary test, which I understand that there will be no interference of BCG, and the results are as good as IGRA with a very high cost effectiveness. And I think that's also round the corner. I think maybe in another 1 month it will be available throughout the country. So we'll be able to diagnose earlier, put them on treatment. We have sufficient stocks of 3HP. So that's one of the another good things. When the 3HP was rolled out in India, it was imported by WHO, and now India has sufficient manufacturing capacity, sufficient procurement. So these are all very, very positive vibes, which I see for prevention. Another thing in prevention is like the adult BCG revaccination thing has started in India. Some limited states have started it right now. Some will do it after this elections have done. So my experience from Kangra is that 25% of the population was broadly eligible. Among those who were eligible, 1/4 gave their consent. And I've been like our team in Kangra, we have been able to vaccinate around 98,000 people who were eligible. And now it's in the last stages that anybody who's left out or wants to get the vaccine. So, very, very good acceptance of the vaccine, a new vaccine, and keeping in view like the whole narrative that was built around the COVID vaccine. So, people still trust that it's the old vaccine, a safe vaccine. So, I think prevention is the game changer. We have reached a plateau with the Himachal was a very high presumptive TB examination rate. We are testing around 3,500 people per lakh population, which is one of the highest in India. So, despite all this testing, we are not finding more cases. So, to further decline the TB trajectory, we need to work actively and more aggressively on prevention. So, right now, like PLHIV and children were the traditional population who were eligible for TB preventive treatment. But later, people, adult contacts were added, and then some more key populations were added. But we are looking forward to a further scale up in the populations who will be offered TB preventive treatment, maybe healthcare providers. I think there are people at risk. So we are looking forward that Government of India will scale up those directions and we get more people eligible for TB preventive treatment. I, as a healthcare provider, would like to take it first whenever it's available, because I don't know whether it will be a latent MDR or a latent this thing, but maybe I can have treatment at a time when I can tolerate the medicines, and rather than a time when I can't tolerate the medicines, so many of drugs to be taken and immunity already down. So I think TB preventive treatment is definitely a very, very big lifesaver, as well as a very, very big game changer in the whole game, I think. And we need to have a big thrust on that.
Yeah, totally agree with you. And another very important point, we have spoken about TPT with so many people, but this is the first time I'm hearing, and such so convincing what you said. It is way better to take TPT than go through the disease and deal with toxicities and medications, and when the immunity is already low, and there is no need for anyone to go develop active TB disease when
Yeah.
TPT is available. So true. And dear Dr. Sood, we just spoke to someone this morning. She never ever had tuberculosis, but and later developed, the first time she got diagnosed for TB was extensively drug resistant tuberculosis. So this is so you are very right. that the TB bug, which is latent in my body or anyone's body, could be drug sensitive, could be drug resistant. It is way better to take adhere to 1 month therapy and probably eliminate the risk of any active disease. So thank you so much for saying that. So important. Dr. Sood, you're given your experience. We would like to hear one more thing from you. Nutrition is a very big risk. Malnutrition is a very big risk factor for TB, biggest in India. There are other risk factors like tobacco, alcohol, diabetes, HIV is of course one of them. So there is a lot more I think people like me and everyone can do to reduce our risk of not only getting latent TB, but also converting from latent to active disease. If you say it, it will be more powerful. So over to you, sir. Thank you.
Well, one of the good things that happened recently was initiating a new initiative, which is the differentiated TB care management. Tamil Nadu did the research, the piloting, and we adopted that with the on a bigger scale. And every patient who's diagnosed as TB, we do a risk assessment with around 16 parameters. The risk scoring sheet is stapled with the treatment card, and anybody who has a risk, he should not go home. He should be admitted in the hospital. He's admitted in the hospital for 5 days. We have earmarked beds for them, and we have trained our doctors. And in case he gets sick, again, he needs to come back. And in case I get any call from any person with TB or his family members saying that the patient is sick and please send us the medicines home, my message is the patient is sick, please bring him to the hospital. He doesn't need to be at home. It is for his safety that you need to bring him to the hospital. So one of the good initiatives we are having is this differentiated TB care. We are screening, trying to manage the comorbidities, and in addition, there is a scheme called Nikshay Poshan Yojana, which initially it receives a very good response. Is the world's biggest crowdfunding initiative that somebody adopts a person with TB, provides nutrition support as well as psychosocial support. So initially, I had a coverage of around 90% among the people who were consented. Somebody is adopting them, and this also contributed to decreasing the stigma. Right now, it's around 25%. People have lost some interest. Maybe people were busy with the elections also. So we are trying to again scale up this Nikshay Poshan Yojana scheme, where and encourage people to come forward and help fellow citizens having TB. So that also will going to be a very, very big game changer, not just in nutrition. It's the psychosocial support. The person feels some confidence so that he can adhere to his medicines. A person who is himself into depression, subclinical depression or clinical depression, he won't be able to take medicines regularly. He won't be able to complete his treatment. So management of comorbidities, including mental health, is a very, very big area for saving lives. See, I openly admit that despite the decline in TB, we have not been able to decline the deaths as we wanted for the NTB goals. We have been able to decline incidence by 50%, which was the midline of the SDG goals and TB goals. But deaths, we just after this differential TB care, we've got a marginal decline. So we've got to work a lot on saving lives. Only then my statement that TB is curable will hold credibility. Right now, we say TB is curable, but people are dying of comorbidities. People are dying of many other issues. Even in COVID, nobody actually died of COVID officially. Everybody died of comorbidities. So we need to manage the comorbidities in a much better way and not only build the capacities of our team, strengthen the health systems, and the health, the deaths, the TB deaths is a trace indicator of the health system. How strong our primary health care is, how strong our secondary health care is. So if we can't save a person with TB, then definitely there's a lot to do on the primary healthcare, a lot to do on the secondary healthcare. So we need to work on that also. TB and AIDS can't be ended in isolation. It's a whole gamut of efforts, I think, and that's what right now what is you are advocating and everybody's advocating, that we need to integrate the services. So I think integration holds the key. Like I told in the initial part of my talk today, that the government of India is having a integrated campaign for HIV, TB, STI, blood pressure, diabetes, anemia. So I think that's something which is going to take off the stigma and get more and more people to know their status. If people know their HIV status, definitely it makes a lot of dent in the transmission, and it makes a lot of big game changer towards the ending TB and HIV goals.
Right, right. Totally agree with you. Totally echo. And thanks a lot for reminding us again, because this becomes a cliche statement that TB is preventable and curable, because it is not for almost 10.6 million people who got TB last year, or about 13 lakh people who lost their lives. I read somewhere that TB devastates and fractures families. It is so true. The people who have lost a loved one will understand how an untimely death can devastate families and fracture societies. It is very important reminder, Dr. Sood, about the integrated health and development. It is so true. We can't pick one goal and ignore other health and development indices. It is so true. Let us hope your words really change things, and this is exactly what needs to happen, what you have just said. I know you are a busy person and you are doing such important work, sir. Thanks a lot for taking your time. But before we let you go, we need to ask few more things. So one thing, sir, is I actually honestly, till about 2 years back, I did not know that the same machine, actually till COVID-19, sir, when COVID-19 had hit us, I
Yeah.
was surprised that the TrueNet machine is being used for COVID test. So I checked with I thought these are different machines altogether. But it took me about 1 year to understand that it's the same machine. It's just the cart, the chip, etc.
The
changes.
chip is
That's all.
different. Yeah.
Yes. So what really amazed me at that time was it, and then I learned that these machines, whether it is CBNet or TrueNet, these can be deployed to test for a range of conditions. So advantage with TrueNet, it is point of care, battery operated, lab independent, can go in the field. Like STIs, for example, HIV, viral load testing, malaria, dengue, chikungunya. In Kerala, it was deployed to test for Nipah virus. So what I'm trying to understand, what I fail to understand is, why are we not deploying these machines for multi-disease testing? A same person who may be coming, depending upon the area, maybe some area, for example, are high in drug use. So what about hepatitis, HIV, TB? I'm just imagining, as a non-medical person, why if I have three diseases, or if I'm at risk of three diseases, why not, for example, if I have HIV, do my HIV viral load testing, do my TB testing also when I go to collect my medicines at 3 months. I don't know the answer. I'm just like trying to seek your advice and insights. Because strengthening lab capacity, sir, will be very different. I was just doing some. I think in India has about 7, 8, 9,000 of these machines. So even if you do say 10 tests a day, you then in 300 days, for example, if you take Saturday, Sunday off. So we should be doing about a lot of tests.
Lot more. Yeah.
है ना? But if you
Yep.
look at the number of tests done as per the India TB report, it is a fraction of that. So basically, what I'm trying to understand is, first of all, the argument that the molecular test machines are very busy with TB program, probably that is not true, because maybe there is some scope to do some more tests somewhere. And even if they are busy, we should strengthen diagnostic capacity. Dr. Sood, Dr. Sangeeta Sharma is a known person in Delhi. She was a strong advocate for preventing antimicrobial
Yes. Yes.
resistance.
Yeah.
And she is saying, unless we have the best of diagnostics at the grassroots, how will we ensure that the healthcare providers are using medicines justly,
Correctly, yeah.
unless we have those tools and technologies in place at all levels, how will we ensure people use medicines properly, rationally, reasonably, and AMR is not fueled? Sorry for, I should not be the one talking here. We are here to listen to you. So over to you, sir, and for your insights.
Uh, Bobby, really very, very well taken point, I think. These are multi-disease platforms, and you just need to change the chip or the cartridge and do the any disease testing. And I think more than 100 diseases we can test from these platforms. And some initiatives have already been done. Like we have an area which is having a high Hep B, Hep C. So we are using the same TrueNet machine which is there for TB for our Hep B and Hep C viral load. So uh, we just needed to procure those chips and provide them, and people were able to get those tests done near to their homes rather than traveling 40 kilometers away. And just imagine a person who's an intravenous drug user, getting him to travel 40 kilometers away for a test. It's very, very difficult. So we are trying to integrate to a small scale, but definitely integration needs to happen at a much bigger scale. When there was a peak of the COVID, I used to say that there are two slots in the machine, program one for TB, one slot for TB, and one slot for COVID. So we need to balance. We needed to balance out both the requirements that COVID testing is also necessary and TB testing is also necessary. So it was the same machine, though my staff was skeptical that how the same machine, so COVID testing we need to have so many precautions. So like initially with the initial resistance, they were able to overcome it. So uh, like definitely it is possible. And these point of care platforms, like what I understand is that the CBNet, the running cost is more, the AMC cost is more, the TrueNet, the running cost is less, the AMC cost is less, and the only difference is the HR, that the CBNet you fill and forget, and with the TrueNet you need some LT needs to be there to continuously process the whole thing. So both have their own advantages and disadvantages, but uh, we need to have more and more NAT machines in every district. Like in my district, I have at least one NAT machine in every health block. So some we got through CSR, some we got through TB division, some we got through the COVID funding. So through multiple sources, we are able to try to get more and more testing facilities. I would like this to be scaled up even further, like some remote areas where sample transportation is actually a challenge. So I would like to have more machines, and I'm looking forward to getting support from some more people. So uh, getting these point of care tests, I think, is a very, very good business proposition also for private labs, because I can tell you, like, one lab in my district had a TrueNat machine, and they earned a lot from that TrueNet machine doing the COVID testing. So it definitely makes sense to have these molecular point of test care testing in the private sector also.
Yeah, so true. So totally. Thanks a lot for letting us know that what we are imagining is already happening in Kangra. Thank you again for reading from the front. And you're very right, Dr. Sood. I was going through one of the India TV reports. I think it is of 2, 3 years back. And there are best practice examples or something like good practice from different states published in each of those reports. So in one of them, it mentioned that these machines, TrueNet, I guess, was deployed because these are battery operated. So they were functioning in Lahore in Spiti Valley for COVID testing as well.
Yeah.
So and this I got reminded of this because, as you know, last month the Stop TB Partnership and others deployed ultra portable X-ray at the Mount Everest
Mount
base
Everest,
camp.
yeah.
So that was, sir, I think 5,400 meters. But in India, in Lahore Spiti, which is 4,000 plus meters, these machines were already functioning sometime since many years for COVID testing, etc. So thanks a lot again, Dr. Sood. Now we'll let you go before, but two last things, sir. One thing is, please let us know what put people first means to you. Second is, please help us all understand the importance of your your background. I know there is a story. Over to you.
Uh, well, for me, putting people first means understanding the barriers and trying to address those barriers. The vulnerable and marginalized people are often left out from the services. I often talk to my community health officers that has any LGBTQI plus community member actually come to you for services, and the answer I get is no. So we engaged with the Himachal Cure Foundation. They came to our meetings. They sensitized our people. So getting people out of judgmental attitudes, means the service providers out of the judgmental attitudes, getting our services to be friendlier towards the community is one of the steps. But definitely, there are a lot of perspectives. The felt need of the community. We need to understand. We had a lot of drug shortages, and despite that, we were able to manage somehow. But definitely, it's a very, very big challenge to put people's needs first. Because for the service provider, it's statistics that how many people I've given Nikshay Poshan Yojana, how many people have got this service, how many people have not got this service. So reporting goes into numbers. So if service providers understand humans rather than numbers, I think that is putting people first. And this thing is very important that we try to have empathy, put ourselves in the shoes of the person who's sitting on the other side. So that makes our service more human, more friendly and more acceptable. And I think one of the best indicators of the quality of TB care would be that how many of the TB patients who are actually satisfied with the TB services and then they want to become TB champions. Right now, it's very difficult to find TB champions because maybe their experience has not been good enough, or maybe the stigma is very high. But when we'll be actually putting people first, maybe we'll be having everybody willing to become a TB champion, everybody becoming willing to become a HIV champion. So that is something I think it's a futuristic thing, a very distant dream, but let us try to aspirate for it and let's try to work towards it.
Yeah, thank you, Dr. Sood. Please tell us the importance of the image which you have in your background. Let us all know the story and the campaigning which you do on the ground.
Well, basically, I started with a very humble research in public health during my internship. My interest was in public health. When I started my job, also, I tried to implement a lot of public health, small interventions. And then I am also associated with some NGOs in my advisory capacity. I learn a lot from that. And uh, I actually try to learn from the people, from my team, my staff. Then I think the biggest thing is that my staff gives me the better ideas than me. So I trust my team. They tell me what's wrong with this approach, what is better. And like I hold meetings with my team, so I get a lot of ideas, lot of cross learnings. And I think this is the whole strength, that everybody learns from each other, and we give the right person the right responsibility, and that makes a real difference. I think everybody has different skills, different strengths, and whatever the strengths are become the strengths of the team. I think that really matters, and listening to everybody in the team and actually trying to work step by step and measure your work. I think that makes a lot of difference. In Himachal, we have a very good work culture. So that also makes a lot of difference. Very good accountability. People really are very, very positive. One of the successes I can tell you is that youth engagement in TB and HIV has been very, very exemplary. The youth are very, very talented. They create reels on social media. They create different types of creatives, candlelight, face painting, a stone painting, which conveys the message much more powerfully than any government official could convey. So I think those are new allies that we are taking. And very recently, we have started working with self-help groups. These are small women groups in the community who are working primarily on microfinance. What common area we want to do is address stigma. If we are able to address myths and misconceptions among the self-help groups, maybe we'll be able to address stigma, maybe we'll be able to create a more open environment. So I think more and more people we engage with, I think the bigger our reach can be. And that's what the public health has taught us, that have more and more partners, more and more uh, people, talk to more people. Communication is a very, very big thing, which I've learned. Uh, I think health systems have traditionally neglected communication. Communication professionals are need of the hour, and I think if we have communication professionals in our team, it definitely strengthens our team. So these are some things I think which can further take us the next step forward. But the basics will remain, and we'll have to work on more things. And like you said, putting people first, a new mindset, uh, open mindset among the health system, and dedication among our team. So that's really, really very important. Motivating our teams is very, very important. I think that makes a lot of difference in how we between good people and outstanding teams. So I think it's a very, very positive vibes. I think I'll conclude with the positive vibes again. 1 HP we are going to offer, and we are offering adult BCG vaccination. So a lot of good things are happening. Differentiated TB care is happening. We just need to strengthen these things further and further to improve the outcomes and improve the penetration, and more communication to address stigma, more communication to have these people engaged with this campaigns. It's a community-driven campaign rather than a government-driven campaign. So those things will further strengthen our this thing efforts towards ending TB and HIV SDGs. So I think definitely it's a long way ahead. I don't see it happening in 25, but maybe by 2030 we'll be able to definitely achieve these milestones.
Totally. Totally, totally. Thank you so much for for sharing so important insights and reflections based upon your decades of work, Dr. Sood. So it's really important to see these not only how we can improve the TB response so that every TB person who goes through the care uh, turns into a TB survivor, champion, and becomes an ally of the program. And you are so right, the response from those who get cured is in the feedback. If we can if as you say, and many others have said that we need to listen to the people we serve, and if those people and those input can help improve the services from patient point of view, from user point of view, like we all expect great services when we call customer care of anything. So if we can really make TB services people friendly, rights based, and probably this your wish will really come true, that every person who goes to the care wants to give back to the program and try to help in the mission of not only TB free, but also, as you rightly said, that TB mission to the TB free is also very deeply connected to so many other health and development programs, and we all need to kind of, move together towards ensuring a healthy and sustainable future for all of us, and not just a select few. So thanks a lot, Dr. Sood. If you have, do you have anything, final thoughts to share with us before we
Uh,
conclude?
Yeah, I think early detection, accelerating the scale up of the new tools, and having more people-friendly services will be the game changer for this current decade. I think if we are able to achieve this, and we're able to achieve financing for all these, definitely I think we'll be in a very good position to end TB and HIV.
Yeah. Thank you so much, Dr. Sood. Totally. Whatever you have said is so true and bang on spot. And we totally, this resonates with us. And I hope it does with so many other people who believe in health for all and all for health. So thanks a lot, Dr. Sood, for talking with us. And I'm really sorry it took more time than I really thought. But there's so much of wisdom based upon your groundwork and the your years you have invested in strengthening, improving programs on the ground in Kangra. All the best to your team Kangra and your leadership, sir. And we really hope to reconnect after a while. Thank you so much again. Thanks a lot.
Thank you, sir.